You're listening to Health Professional Radio. My name is Wayne Buckler. This morning, my guest is the CEO of the Rural Health Alliance, Gordon Gregory. Gordon's going to tell us about his organisation and how it fits into the health system in Australia. Gordon, tell us first of all about the footprint that you cover for our international audience.
Well, Wayne, thanks for the chance to talk about it. The National Rural Health Alliance is the peak non-government organisation in Australia for rural and remote health. So we bring together 37 national bodies. It's a huge network, really is. So when I say national bodies, what I mean obviously is that we don't have any state ones or territory ones. We don't have any regional ones or local ones. But we've got 37 national organisations. Now, these 37 can be categorized, to give clarity to what they are in a number of ways. Firstly, there are, if you like, organizations that self-define because they've got three characteristics. They are national bodies, which are rural or remote, and health. So a good example is the Rural Doctors Association of Australia. It's a national body, it's about health, and it's rural. Another example would be the Council of Remote Area Nurses, which as you can tell from the title, is, again, remote, not rural, is nurses, and it's national. So the first group of organizations among these 37 are those that self-define because they're national, rural, or remote health bodies. The second group are comprised of the rural interest groups of national health organizations. So an example is the Australian Healthcare and Hospitals Association. It may not be a member in the Rural Health Alliance because it's not rural, but it has a rural interest group, a rural policy group, which is a member. And we've got quite a number of these. Another example would be the rural interest group of the Australian Psychological Society. The APS, the Australian Psychological Society, as you and your listeners know, is not a rural organisation, but it has a rural interest group comprised obviously of rural psychologists. So it's that rural interest group which is in the Alliance. What this means is that all 37 of our member bodies are passionately rural and remote. So we have very few organizations which are, if you like, city-centric. In fact, we have none which are city-centric. The third class of member, a smaller one, is comprised of national rural organizations that are not actually health bodies per se, but which have a demonstrated interest in health. And the best example is the Country Women's Association. It's been around for many, many decades, as you know. It's a national rural organization which is not actually a health body, but which has got a clearly demonstrated interest in health. So as we all know, the Country Women's Association has been weighing babies and having baby centres, clinics for many, many decades. So these 37 member bodies in the Alliance, they consist, some of them are consumer groups, many of them are provider groups, and some of them are health professional groups. So we've got organizations which are icons of the establishment like the RFDS, the Royal Flying Doctor Service. We've got small organizations which don't take any government money at all like the Country Women's Association. We've got service providers like Frontier Services of the United Church. We've got National Aboriginal Community Controlled Health Organisation, which is one of three Indigenous bodies, the other two being Indigenous Allied Health Australia and Australian Indigenous Doctors Association. So we've got consumers, we've got health service providers, and we've got clinicians, all of whom are passionately rural. And obviously you can tell that what this means is that we're not just a health alliance, we're an extremely strong and useful voice for rural affairs. So even though we're called the Rural Health Alliance, we look very, very broadly at the field. We're concerned with the so-called social and economic determinants of health. So things like jobs. How can we get more jobs in rural and regional areas? Things like public transport. People will be well aware that in remote and rural parts of Australia there basically isn't any. Things like aged care for people living with a disability. So we have a very, very broad mandate. And we bring that to bear through the good relationship we have with the Department of Health and with governments and shadow oppositions in Canberra.
Gordon, the image that comes immediately to my mind is of a lot of cats running across a paddock and you're trying to herd them in one direction. It is an extraordinary collection of organisations. How does it fit together and make decisions? How do you get a consensus with such a broad church?
That's a very good question, Wayne. And it is sometimes a bit like herding cats, but it's a wonderful sector with which to deal. I mean, the people in Australia's rural remote health sector are wonderful. They are passionate. They're all minded to do the same thing, that is to make sure that people in country areas do not have any worse health than people in the cities. Why should they? And to make sure that they have access to good services. So what happens is, briefly, is that these 37 member bodies nominate one person each to our council. So we have a council comprised of 37 plus 4 other individuals who are nominated for particular skills. So the Council of the National Rural Health Alliance is the body which will determine how we spend our scarce time. So we've got a relatively small team of policy people, and we've got 3.5 or 4 policy persons here in the office working with myself here in Canberra, which is where we're based. So it's council, that is the groups coming together will determine whether we're going to work on maternity, the loss of maternity of birthing services, or whether we're going to work on Murray-Darling Basin issues related to economic growth and development, or whether we're going to work on chronic disease or workforce shortage of specialists, whatever it is. So that council will say, we want to put this as a priority. I'll come back in a moment, if you like, and talk about what some of the priorities are. Our then job as a staff here based in Canberra is to draft a proposal relating to that issue. So council will have selected it because there's a challenge. So let's say, as an example, let's take mental health. So mental health is a particularly troublesome or challenging functional area in rural remote areas. So council will say we must be we must be at the table, we must be on the agenda where mental health is concerned. So our job as a staff here in Canberra is to write what it is about mental health, mental poor health, mental illness in rural areas which is particular to the bush, and how in particular it can be resolved. So, what are the programs or policies which we might be proposing to state or Commonwealth governments which can help? So council is the one that determines we're going to work on mental health. Council is the ones who help provide us with the information, because they're all out there in the real world actually working in health. And then this document will go back and forth, as you would imagine, by email to members of council, who bring to bear the view of their member body until finally we've got an agreed position. So, and as you say, it does, as you imply in your question, it does sometimes take a while. Once we've got an agreed position, Wayne, this is quite authoritative, this is quite influential. We can go to the government of the day, the Commonwealth government of the day, or we can go to a state or territory government, or we can go to the oppositions, who of course are busy considering their policy positions for the next election. We can go to them and say, look, guess what? In relation to rural mental health, 37 bodies in the Rural Health Alliance have agreed on this. And of course, we're always trying to be positive, so there's no sense in simply reiterating what people know about the challenges. People know that things can be crook. So our role is always to try to come to the table with suggestions for how policies or programs can be improved and changed, so that mental health in the bush is better, so the mental health services in the bush are better. Now sometimes we don't agree. I mean, that's the implication of your reference to herding cats. So I'm sure it's been the case over the years that we have actually, one of the benefits of the work the Rural Health Alliance has done is to discuss things behind closed doors on which we have not readily had an agreed position. So, for instance, some of the workforce issues, relating to, say, nurse practitioners. I mean, nurse practitioners, as you well know, is, if you like, a sort of a moot point. I mean, why do we not have hundreds more nurse practitioners in rural and especially remote areas doing the job of quasi-doctors, if I can call them that? The answer is, of course, that there are differences of opinion about whether this would constitute a second-rate health service, whether it's who's going to be responsible for their work, whether they're overseen directly by medical doctors and so on. So there are lots of issues, and we might come out of the room, the locked door, when it comes unlocked, there's a bit of blood on the floor, but we've actually developed something closer to an agreed position, but don't have one. So there are a number of issues like that, which we've discussed over many years, and the discussion of which has been useful, but we still do not have an agreed, strong, unequivocal National Rural Health Alliance position.
Gordon, it's an extraordinary task you've undertaken in combining to one position, but it is something that governments, essentially really only want to deal with one organisation with a unified voice. So you're to be congratulated on the extent to which you've brought together the various arms in rural health into a single unified view. You've been listening to Wayne Buckler on Health Professional Radio, and I've been chatting with CEO of the Rural Health Alliance, Gordon Gregory, about the organisation and how it fits together. Gordon, we're running out of time here, but let me ask you one final question. If there's one thing, one misconception amongst your clients, the politicians, patients, that drives you nuts and keeps you awake at night, what is the one message you'd like to leave with us?
Well, I think it's the balance between the good news and the bad news. I mean, the essence of the National Rural Health Alliance's work is that we are saying to policymakers and health service managers across the nation, we're saying don't forget that things are worse in the bush. Don't forget that health status is poorer. Don't forget that access to services and workforces is more difficult. Don't forget that the cost of delivering any bundle of health services is greater because of transport costs and so on and so forth. Don't forget that in aggregate, people in rural areas have lower incomes. Don't forget that there's a greater proportion of older people in rural areas. Don't forget that some of the health risk factors are poorer, so there is a greater rate, sadly, there's a greater rate of smoking. This is an issue which interests us in particular, why it is that smoking rates have come down in the cities, not in the country areas. There's a greater rate of dangerous use of alcohol. Surprisingly, there's a greater rate of sedentary lifestyle, so people often think of rural areas as being places where people are sort of naturally fit and well. Well, that's not the case. Sedentary lifestyles are actually more common in rural areas. So, on the one hand, Wayne, we're saying to anybody who will listen, but in particular those who are in a position to make a difference, like researchers, parliamentarians, ministers in particular, government departments, we're saying to them, hey, look, there are particular issues and challenges, and we would like to meet them, and we've got some suggestions. We want to work with you. We've got some suggestions about how these challenges can be overcome through different policies, through different programs. Multi-purpose services. What a wonderful example of a model of health service. The multi-purpose services, there are 126 of them scattered all around small communities in Australia, and they see the formal acceptance of the need to merge or pool the funding from the Commonwealth for aged care with the funding from the states for acute care or hospital care into these wonderful things called multi-purpose services, which cover all those bases and more besides. So on the one hand, our job is constantly to say, look at us, don't forget us, because in many respects we're worse off. But on the other hand, and this is what I would like you and your listeners to understand, on the other hand, if you've got the basic perquisites for life, meaning that by that I mean a job, a good job, a good family, a good home, and access to some of the other things which access to health services and educational services, then life in rural and remote Australia is the best in the world. So what we're saying is, in a sense, I suppose, we don't want to be too successful with reminding everybody that things can be crook, because then, of course, we're shooting ourselves in the foot. People won't come. People won't be happy. People will be stressed. We won't be able to get podiatrists to come to the bush. We won't be able to get mental health nurses to come to the bush. We won't be able to get doctors to come to the bush. So we're always trying to balance things, Wayne, as between the look at us. We are a critical part of Australian community, society and economy, but we've got special needs which we want you to take account of. But also look at us. We're wonderfully creative people. We're innovative. Some of the services we've created in the bush couldn't happen in the city areas because of the greater institutional or organizational barriers. In the countries, there are few people around, so the organizational or institutional barriers are much lower, smaller. So we're proud of the innovation, we're proud of our resilience, we're proud of the fact that in country areas you can get great community spirit. We're proud of the fact that people actually self-declare that they are more happy, whatever that means, in rural areas than in the city areas. We're proud of the fact we don't have congestion and traffic, problems and so on and so forth. So the Rural Health Alliance has got a job to do, but the best way we can do it is by projecting this balance that life in the rural areas is, in some instances, particularly needy, but in others, it's the best in the world.
A balanced view indeed. Gordon Gregory, thank you for your time this morning. Gordon's the CEO of Rural Health Alliance. Now, if you want more information on the Rural Health Alliance, by all means go to the website at www.ruralhealth.org.au. We'll also have a transcript of this interview and a sound archive of it up on our website at www.hpr.fm. You've been listening to Wayne Buckler on Health Professional Radio.